Dr. Houghton, welcome so much to the Cutting Edge. We're here at SAGES 2025. My understanding is you're talking about the advances, the cutting edge in foregut surgery. Is that where we're at?
Yes. So our session was really exciting. We got to talk about all the future state-of-the-art treatment strategies for foregut surgery.
Really? Can you walk us through what are some of the big ones coming out?
There's several, and it's actually a really exciting space because a lot of innovation is happening in minimally invasive, including robotics and AI. So that was a hot topic in our sessions. But then specifically for foregut, we have technologies like EndoFlip, which is used in the GI world too, but we're starting to bring that into the OR and tailor operations and get more objective data. And then there's new technologies like innovations just for acid reflux as well. There was the Omega Cuff and Reflux Stop are two that come to mind that are FDA, or one is getting FDA approved and the other is FDA approved already. So really exciting stuff in foregut.
Well, that sounds amazing. So when you break the AI part, what was the conversation around AI? What did it involve?
Obviously robotics has been here for a long time and it's expanding, but I think the discussion is more around not just the technique of using robotic surgery for foregut cases, but how AI is going to alter the efficiency of how we do that. So not only can we review and go back and learn and train, but maybe overlay and allowing us to understand tension on tissue and that kind of thing. And then eventually maybe autonomous surgery, or at least parts of surgery, which should be really interesting. I think everyone's a little nervous about that. But at the same time, I think it can do portions of the case that, maybe you don't need the most technical skills to do.
Oh, absolutely, absolutely. And then you were saying there's some devices. We have one here?
We do.
Yes.
So there's a couple devices. This one is Reflux Stop. I don't know if you can see that, but it's a silicone ball. This is interesting because it takes reflux surgery and it's giving it a different light. So most of, when you think about reflux surgery, you're thinking about closing the hiatus and then creating a fundoplication. And this surgery is doing that, but then this ball is being imbricated into the stomach to try and support the valve, but then prevent the recurrences, which is always the Achilles heel of foregut surgery, is that hernia recurrence. So if that ball is kind of stabilizing the tissue below the diaphragm and can't go back up, maybe our recurrence rates will be a little different.
Really?
Yeah, so this has had good success in Europe. Hopefully FDA approved by the end of the year, so that'll be exciting. But that's one of the new innovations in acid reflux surgery.
And then you also brought up EndoFlip. Do you consider that to be either the standard of care now that included, or is it becoming the standard of care in the field of any sort of reflux surgeries?
I actually do. I think for Heller myotomies, the GIs are using it for POEM, surgeons are using it to tailor myotomies and make sure that we have adequate surgery. And I think there's really good data there that then we're expanding and trying to see if we can take that knowledge from Heller myotomies and expand foregut surgery. So there's always a question of how tight do you close the hiatus or the diaphragm to recreate the barrier for acid reflux, because we don't want to cause dysphagia, but we want the patient to not have acid reflux long term. And Dr. Mike Ujicki is the leader in EndoFlip and foregut surgery. We're all kind of trying to replicate that work to make it standard of care. It's not there yet, but I do foresee that at some point in the near future it will be.
I was amazed. I was up in Colombia and I got the opportunity to kind of see somebody as they were using it. And this is anecdotal, obviously, but
yeah.
It was like 80% was coming of their anti-reflux was coming from the hydrohernia repair itself. Is that not correct?
Yeah, that's correct.
Yeah.
We're learning a lot more about that, and I think we've always known that there is multiple components of the barrier for reflux. We know that it's the diaphragm, it's the valve, but it's also there's a physiologic component. So we're really paying attention to that too. We know the diaphragm has to be solid because that's 80% of it, but then that other 20% might be the margin of having really good outcomes and having marginal outcomes. So we're looking at, is it a connective tissue disorder? Do we have to start looking at PRP like they do in ortho? Or, are we using EndoFlip to tailor that wrap? Just different ways to augment that valve and really make that last 20% count.
And of course, obviously, you're an expert in this. When you look at the hiatus, how do you repair the hiatus?
Yeah. I'm mostly robotic, so I love technology, and so I'm using robotic surgery. I had, it's changed a lot, which is so fun in our field. If you asked me 2 years ago, it would have been different. Mostly posterior closure. However, considering a lot more anterior stitches, because we know that's the weakest point of the hiatus, and that's where it tends to occur. So there's a kind of a movement to put our stitches there. Mesh is always a hot topic. I'm a pretty liberal mesh user as well to prevent that early recurrence and stabilize the repair early on. And then I use EndoFlip intraoperatively, so I'm tailoring it to the numbers that we know have the best success at this point. And then we're doing partial fundoplication. So we're trying to eliminate the side effect profile, but keep the long-term acid reflux results.
And you're talking about toupees or doors?
Well, I'm doing mostly toupees, but there's newer fundoplications that we're doing too called Watsons and LINX.
Oh, really?
Yeah, there's the LINX is like a toupee on its side. It's like an anterior-posterior repair where you take the posterior fundus and wrap it one way and the anterior fundus the other, which is one of the techniques for toupee, except we're not putting it so posteriorly. We're actually kind of using the lesser curve as a backstop. That really got popular because of CTIF, which is another innovation within foregut surgery. But CTIF really showed us that that physiologic valve used the lesser curve as a backstop. And so this fundoplication replicates that more closely.
Well, that's interesting because, yeah, my understanding was always, I mean, when you look at toupees, I switched to toupees before, and I do some LINX now too, but because the side effect profile, obviously, it's a lot better than the Nissen. People tolerate it a lot better. And so, when I was looking at the data, even though it's not as old data, there's not nearly as much data as Nissen, it appeared that it was roughly equivalent, in terms of outcomes. Am I wrong in what I'm reading in the data, or does that seem correct?
No, that's correct. I think most of the societies have shifted to a partial fundoplication. And then you brought up LINX, which actually didn't get talked about as much in our session. It usually is a hot topic.
Yeah.
But also, I think, an interesting, still a player in the game.
Yeah, it's one of those.
Reflux.
I went both ways on it. I mean, I waited 10 years for data to come out, and we've had really good success with it, a lot of patients, but it's like anything else, patient selection, doing it properly.
Exactly.
And I think you're going to get pretty good, or at least really good outcomes, but I'm a little surprised it hasn't come up so much.
Yeah, it is interesting because some of the data on that is showing decreased recurrence rates, really great acid reflux. I think that the Achilles heel for LINX was dysphagia rates are a little bit higher. And a lot of people have bad experiences with either Angel Chick or the band, and they kind of compare it to that without really understanding that the mechanism might be a little different because it's compliant. But I think that's why it hasn't caught on maybe as well as it should have.
And I laugh because you say, I mean, obviously that's the Angel Trick caused all that issue. And,
Yeah.
and so when I first started doing it, even though I looked at the data and I was like, actually, if you look at the data, it's not that bad. When I say not that bad, it was really good actually, but not what we saw with Angel Chick.
Yeah.
And yet when I would bring it up, I'd be like, yeah, I'm doing LINX. Because everybody just freaking out on you. And you're like, yeah, but it's actually working. I mean, we've had good success with it. It's like anything else. It's not perfect. But I want to go back to the mesh. You talked about you do use mesh.
I do.
What's your mesh of choice and what technique do you use?
I'm using Phase XST at the moment, switching to a reverse C position, trying to cover that left anterior portion of the cruce, which we think is the weakest. And so most of my cases, I'm putting it there. I still think there's a role for posterior. If it's a really early small hiatal hernia, the pillars of the cruce come together really nicely. I still think a posterior repair with a posterior mesh is adequate and probably really good. But in anything, larger, it has weakness in that upper left area, I'm gonna switch it and turn it into the reverse C.
And are you suturing it in?
I am at this point, yeah.
And how much, are you doing it continuous or are you doing interrupted?
Yeah, I just do a couple interrupted stitches, 2 or 3 interrupted. I've played with different things like buttressing it in and like making it a part of my diaphragm repair. And it's an interesting repair and it looks really nice, but I don't know if it actually changed much. So some of those things, I don't they're fun to play with, but I don't know if they make a huge difference.
Oh, absolutely. I think the part about hiatal hernia is that it looks so pretty when you're done. And you're like, this is going to be gorgeous. And then you have this recurrence, sometimes a year out, and you just go, it looks so beautiful.
Right.
Like I swear I did everything right, and yet you're fighting this battle that I don't think we definitely haven't perfected it.
No, we haven't. And it's really, I think that's what is so challenging, is that you could be technically great and have what looks like to be the perfect operation. And yet we have recurrences, and that's really what we still need to figure out. Is there a range that we need to figure out with EndoFlip? Is it that it's a connective tissue disorder and that diaphragm is going to weaken over time? And so I know there's some research in like vascularized pedicles, or we're doing PRP and injecting PRP into the diaphragm to see if that helps. But it's challenging and humbling at the same time, but it makes it fun that we can make a difference in the field if we can figure it out.
Oh, absolutely. And then let's say they have a recurrence. When do you look at a recurrence as something that needs to be fixed, and when do you look at it as something you're just going to monitor?
Yeah, not every recurrence needs to be fixed. The cutoff standard is usually over 2 centimeters, but I'm really looking at the whole picture. I want to know, are they symptomatic? Can they be controlled on antacids? Any recurrent situation is going to be a little more challenging. So I'd like to hold off until our hand is forced to do that. So it's a lot of discussions with the patient. What are they trying to achieve? But if they're symptomatic and it's inhibiting their daily life and they had good results the first time and then they recur and their symptoms are back, I'm likely going back in.
Absolutely. And when you're pre-oping somebody for any fundoplication, what testing do you require for your pre-op?
So I think for my index procedures, we're doing an EGD with usually pH Bravo study. We'll do that for any hernia less than about 5 centimeters. If it's a symptomatic paraesophageal, you may not need the pH Bravo study, but we're pretty routinely doing that. And then we're doing a video esophagram. Our USC protocol has a screening component to it for motility. So if they pass that, then we're skipping manometry. And then recently, we've been adding EndoFlip into our preoperative workup just because we're using it intraoperatively. We don't want to be surprised by low numbers that are then going to maybe change our decision-making intraoperatively. We want to be prepared for that.
Imagine a platform that connects you directly to a private group of surgical colleagues. Within the app, you interact socially with colleagues, post your own surgical videos, scan the library for relevant content by type of surgical procedure, anatomy, or even specific operative step. You'll be invited to live webinars and build your network through conferences hosted on the app, all while maintaining your privacy. Surge On, where surgeons go to explore, discover, and learn.
What is it about SAGES as a society that really interests you, or that you find is a good place for the foregut and bariatric community to reside?
Yeah. SAGES has always kind of been in the leader of innovation and minimally invasive surgery, and we fall right into that space. So I think it's a natural fit for us to be here. They're so supportive and they're well known in the medical community, surgical community. So that's also great. I think their focus on training and partnership with industry just leads to a really cohesive group where you're getting everyone involved to really elevate the field of surgery. So I always find it really nice to be here and collaborate with all my peers.
Absolutely. And could you kind of give us your history as you moved up through SAGES? How did you get involved with it, and then what other roles have you played in the process?
It was mandatory for me to be involved in fellowship. If you weren't involved in SAGES, you were not considered a candidate for his program. It was Dr. Santiago Horgan. So he was very big into SAGES. So as a fellow, that was kind of ingrained in us. And that was my first introduction. We submitted videos. We were making sure we had papers that we were contributing to the education. So that was my first look. And then I came to SAGES every year after that. I think my work with Intuitive and in industry helped kind of then get me on the podium because I was starting to become a little more nationally known. And once I was invited to speak, I ended up being moderating, and it just snowballed from there.
And what would you tell somebody coming out of residency or fellowship to do if they want to be a part of SAGES?
Well, definitely register. Find an abstract or a cool video. I think that's the best way to get in and actually get the feeling of what SAGES is, and to share your work is really important. And I would say, just for any of those, either medical student, residents, fellows, everyone in your field is here. So many big names are here. It's a great place to network. People are wanting in this setting to collaborate, and we're going out and having fun too. So it's a nice, low-key place to really interact with the big guns in surgery.
Well, I want to end with, I always say there's a difference between experience and knowledge. Obviously, we have our book smarts. All of us have gone through the educational process, but the years of experience that you develop, and then there's a wisdom that comes with that. And there's always that thing you've learned that you've only learned it when dealing with the patients because of the experience you've had. Is there that key point or that, let's say, pearl of wisdom that you can go ahead and announce to the rest of us?
Always keep learning. I think as I become more known as an expert, I think one of the things that makes me good as that is that I'm continuing to push myself to be better, to know more, to take the best pearls of everyone else and bring it back home. So always keep learning and keep that curiosity, and then I think you're gonna be the best surgeon, provider for your patients.
I think you actually proved that earlier on when you said if you said it 2 years ago, it would have been different. It shows that you're continuing to advance and change with the time and what you're seeing. So that's exactly what you just told me.
Yeah.
Well, thank you so much for your time.
Absolutely.
And,
Thank you.
Hope you enjoy the rest of the time of your SAGES.
Thank you. Thanks.